If we are delayed, Divago, you probably needed to show your face to say, look, we have 2-3 minutes.
Are you ready? That is there tá faltando alguém?
Não, ele vai falar, ele só aparece a carinha e fala, gente, por favor, 2 minutos, né? O tempo acabou. Mas Gustavo, Professor Russell said that you probably passed 20 minutes because he has something
No problem.
to share, so it's okay. So you have 22, 23 minutes.
Ok. É 1h30 a sessão toda, com perguntas, né?
São 20 minutos para cada um, apresentador.
Boa sorte. Ah, mas então estava tudo errado lá, Divago, na programação. Estava 40.
Good morning. My name is Patricia Rocco. I am the president of the Brazilian Society of Physiology, and I'm also full professor of the Federal University of Rio de Janeiro and member of the National Academy of Medicine and the Brazilian Academy of Medicine here in Brazil. It's my great pleasure to start the symposium entitled Multiple Organ Damage Induced by COVID-19, Physiology and Pathophysiology. Today we'll have different presentations. The first presentation will be performed by Professor Paolo Pelosi from the University of Genoa, Italy. Professor Pelosi is full professor in anesthesiology and intensive care medicine and the director of anesthesia and intensive care in University of Genoa, Italy. So he'll talk about the different phenotypes of lung damage. Professor Pelosi, please.
Thank you very much. And it's a great pleasure. Do you hear me?
Yes, perfect.
Do you see my slides?
No. Now, yes. I can see your slide.
So
Just
now,
click in the first
all
one.
of you,
Perfect.
you see my slides?
Yes, perfect.
Perfect. So thank you very much for a kind invitation. I remember the FESME meeting in person, and they were lovely from scientific point of view and social point of view. So we will discuss a little bit about experience on different phenotypes in lung injury in COVID. There is no conflict of interest for this lecture, and this is really a result of the work of a multidisciplinary team, both from San Martino Polyclinical Hospital, but also a great thank to the collaboration with Professor Rocco from Universidad Federal de Rio de Janeiro and University of Pennsylvania, as well as our radiology department. And of course, all physicians and nurses who contributed to this project. First of all, I would like to share with you some few data that we obtained by cryobiopsy in COVID-19 pneumonia. Cryobiopsy are a technique which is commonly used for diagnosis and monitoring of lung cancer. And we use this technique with the support of our interventional pulmonologist to obtain samples of the lung just 20 minutes after death and during mechanical ventilation. And we were able to identify different pathophysiological patterns, like the early DAD pattern, as you can see here with the black arrows, the complete lesion of the epithelial side, and with the red arrow, the hyaline membrane. And this is typical at the CT scan of quite relatively well-elevated areas. The so-called mid-DAD pattern characterized by increased alteration in the alveolar capillary barrier with some microthrombosis and progressive development of fibrosis, and these areas are typical from the CT scan in the ground glass areas. Then the LADIAD pattern, which is representing a complete disorganization of the alveolar capillary structure, and this is particularly localized in the dependent part of the lung, in the so-called consolidated or white areas. We also were able to identify a particular type of alteration, which is the so-called honeycombing with mucosinosis, so gelatinous infiltration in the alveoli, not edema, and increased thickness of the interstitium with the proliferation of smooth muscle cells, which identify a complete disorganization of the fibrotic response. So overall, we were able to identify pneumolysis, vascular lysis, alveolar cell infiltration, alveolar mucosinosis, and fibrosis of mid-LADIAD pattern. We also measured the amount of collagen in the lung from this biopsy, and we identified two patterns, one with more, of course, air spaces and less collagen, and other pattern with higher amount of collagen. However, when we compare this amount of collagen directly measured and quantified with a radiological score, for example, the CADO score on the CT scan, we found that if the score is low, it's very likely not to have any collagen, but it was not predictable of presence of collagen or not. And this was the same when we performed the quantitative analysis, in this case associated with the gas fraction, but similar results were obtained with tissue mass fraction. So this means that when we have an alteration in the lung in COVID-19, we cannot predict a priori with qualitative or quantitative analysis if these areas are more or less associated with increased or not collagen. So this can explain why some patients with very damaged imaging may resolve quite easily in 1 month, for example, or others that may maintain alteration in the lung for a prolonged period of time. We also identified two main phenotypes. This was one very first study published on May 2020 at the beginning of the pandemic. The so-called phenotype 1, characterized by multiple focal overperfused ground glass opacities and normally aerated areas, and the phenotype 2 with patchy RDS-like pattern, inhomogeneously distributed with hyper and hypoperfused lung regions, both associated with phenotype 1. The phenotype 1 is characterized by the fact that it might be maintained with successful non-invasive respiratory support, while phenotype 2 is usually require prompt endotracheal intubation. We did another study in which we look at the relationship between the amount of densities in those patients who were not directly admitted to the ICU and were associated with oxygenation impairment and worse outcome. We found that most of patients outside the ICU did not present densities or atelectasis. 1/3 of the patients small atelectasis, and 1/10 of the patients large atelectasis. And these were associated with deterioration in oxygenation and also with progressive worse outcome. We measured that the normal lungs weight around 800 grams, while RDS lung around 1 kilo and 800 grams, with an excess tissue in the traditional RDS of around 1 kilo, which is equivalent to 100 to 25% higher than the normal lungs. The COVID-19 phenotype 1 was characterized by an average weight of 1 kilo and 100 grams, equivalent to an excess tissue of around 300 grams, around 37% higher than normal lungs. Differently, the phenotype 2 in COVID-19 lung weight was around 1 kilo 600 grams with an excess tissue of around 800 grams, equivalent to 100% higher as compared to normal lungs. So we performed a dual energy computed tomography, and this is the first case that we did in our hospital, in order to relate the amount of aeration and tissue with the distribution of blood volume, which with this technique is associated with pulmonary perfusion. So we were able to match in the whole lung the aeration and blood volume. And we first investigated around 35 COVID-19 patients admitted to the ICU, and half of the patients were maintained with non-invasive respiratory support, and 23 patients required invasive mechanical ventilation. And as you can see here, the distribution of normally aerated tissue progressively decreased from ventral to dorsal, while the amount of non-aerated tissue increased again from ventral to dorsal, while poorly aerated tissue was homogeneously distributed. Differently from traditional RDS, we found that blood volume distribution, so blood volume perfusion, was mostly non-gravitational and mainly distributed in the ventral lung regions. So the distribution of aeration and density was more in the ventral lung regions in the normally aerated tissue and in dorsal region in non-aerated tissue, but the distribution of perfusion was higher in the ventral lung areas with less densities compared to the dorsal areas with more densities, with an anti-gravitational aspect. We were able also to describe the distribution of aeration and blood volume perfusion. And you can see here that the wasted ventilation, so death spray plus glass blood volume ratio higher than 1, was around 70% in the ventral and 25% in the dorsal. The area with gas blood ratio below 1 were more or less distributed homogeneously, while shunted areas, of course, progressively increased up to 40% in the dorsal lung region. Interestingly, 1/4, 1/3 on shunted areas were characterized by non-perfused, non-aerated lung areas. So we moved from phenotype 1 to phenotype 2, and we found that the oxygenation was a very good parameter to describe this further evolution. You see here that patients with normally aerated lung tissue around 20% were characterized with PO2 ratio around 100%, while patients with normally aerated lung tissue around 60% had a PO2 ratio above 150%. Not so much importance as correlation related to poorly aerated lung tissue, while non-aerated tissue was symmetrical to aerated lung tissue, and again, when non-aerated tissue was equivalent to around 20%, the PO2 was above 150, while non-aerated tissue was higher than 40%, PO2 was below 100%. So overall, the PO2 ratio was very nicely correlated with the lung tissue gas blood overall mismatch. And the true shunt was independently associated with PO2, suggesting that oxygenation is the main dependent on the evolution of this lung disease. Then we look at the amount of different areas of the lung in non-invasive respiratory support patients and invasive respiratory support patients. And you see that the main difference was characterized by the difference in terms of normally aerated tissue, not much in terms of poorly aerated tissue, but major difference in non-aerated tissue. Most importantly, when we compare the different areas of the lung, you see here that both of them were characterized by almost 40% of wasted ventilation, while the low VAQ ratio were higher in non-invasive ventilation compared to invasive, while on the other side, the shunted areas were higher in invasive compared to non-invasive. So we developed a model in which patients who can maintain non-invasive ventilation are characterized by high wasted ventilation, by low VAQ ratio responding to oxygenation, and lower level of true shunt. Differently, patients who require mechanical ventilation are characterized by wasted ventilation again, but less amount of low VAQ ratio and high amount of true shunt will require higher level of FiO2. Then we look at the amount of recruitment in this type of patients, and then you can see here that we characterize patients less recruitable and patients more recruitable. Overall, we found that most of patients with COVID-19 are not recruitable patients, and the amount of alveolar recruitment was around 2.7% of the total lung, with amount of alveolar recruitment of around 39 grams. So there was poor alveolar recruitment with higher PEEP, a 16 centimeter water and recruitment maneuver in less and more severe cases of COVID-19. And the excess tissue mass was around 800 grams in in phenotype 2 equivalent to recruitable tissue of around 3% of the excess tissue mass. This is completely different pattern as compared to traditional RDS, in which the recruitable tissue is around 20%. And this was independent from the low or high compliance with early or late CT and survivors and non-survivors. Further, there was no correlation between alveolar recruitment and excess lung weight, which means that the excess lung weight was not due to the edema as in traditional RDS. Further, there was no correlation between alveolar recruitment and the variation in venous admixture, which suggests that the possible increase in oxygenation due to the change in PEEP or change in position are mainly due to decreased cardiac output and redistribution of regional perfusion, but not alveolar recruitment. This is also studied from Chiara Robba, looking at the effects of recruitment maneuvers, and you see in light blue the effects on oxygenation, in orange the effects on CO2, in dark blue the effects on cerebral oxygenation, and in the gray the estimation of intracranial pressure by nerve sheath diameter evaluation. And you see that the recruitment maneuver has no positive effects in terms of oxygenation, but even a deterioration in oxygenation in the brain and an increase in the intracranial pressure. On the contrary, prone position was associated an improvement in oxygenation in the systemic blood and in the brain, not so much as we expected as compared to traditional RDS, but also by a slight increase in intracranial pressure. We look also at the possible effects of non-invasive support and inspiratory effort on lung damage. This is an analysis from animal lab showing that the interstitial pressure and oncotic pressure may change during higher or lower inspiratory effort. More importantly, the gradient between pressure in the capillary and the interstitium and alveoli progressively increase when inspirative effort is higher and mainly in the most dependent part of the lung. And this is much lower when the inspirative pressure is lower. So we look at the possible effects of early or late intubation, and we found that early intubation was characterized by less increase in excess lung tissue mass, and all positive parameters were less in the early as compared to late intubation. There was also no difference in terms of recruitment, suggesting that the potential effects on patient self-inflicted lung injury are not due to progressive edema and atelectasis, but are due really to a progressive necrosis and consolidation. These are very recent data from the Brazilian team and the German and Italian team, and you see here that we have different phenotypes. Patients who progressively worsen from the day 0 and the day 7, patients who improve the lung function, patients who do not change, and patients who remain stable in the bad condition. Interestingly, what we found is that the change in aeration loss was not dependent on the gas fraction, while the aeration gains of those patients who improved are related to the gas fraction, and lower is the gas fraction at the beginning, higher is the amount in the aeration gain. So the time has a particular effect in the evolution of aeration. So to conclude, COVID-19 is a typical primary RDS with primary and vascular lysis, with gas volume substituted by cellular necrosis, cellular infiltration and fibrosis, consolidation with higher perfusion in non-dependent lung region, with poor and no recruitment with high PEEP and prone, and response in oxygenation mainly associated with redistribution of perfusion, but not better aeration or recruitment. We have hypoxia with low lung weight, with low recruitability, high compliance, and low inspiratory effort, and high venous admixture is mainly characterized by low VQ in the poorly aerated tissue and high wasted ventilation. So we have a good oxygenation response to high FiO2, and non-invasive support is very effective. On the other side, hypoxia is characterized by high low lung weight, low recruitability, and low compliance with high inspiratory effort, and high venous admixture is mainly due to high true shunt in the non-aerated tissue. Also in this patient, we observed high wasted ventilation. But these patients are poorly responsive to high FiO2 and high pressure, and intubation is needed. So we move from hypoxia phenotype T1, where high flow oxygen nasal therapy, CPAP, or NPPV might be helpful, but as soon as we observe a deterioration in gas exchange and especially oxygenation, we are moving to an unhappy hypoxia in the phenotype 2, and these patients require prompt intubation and invasive mechanical ventilation. For those of you who are interested in an overall expert consensus statement for the management of COVID-19, I suggest this recent paper that we published looking at the use of non-invasive ventilation, the use of intratracheal intubation where the patient is deteriorating, the use of prone position and ECMO in these patients in selected population, in the long weaning and the use of tracheostomy between 1 week and 2 weeks, and the mobilization in the progressive phase of weaning of this disease. Overall, this general principle may help in the management also of other viral and not viral pneumonia, and of course, for future variants of SARS-CoV-2 strains. Thank you very much.
Excellent talk, Paulo. I'm so proud. Let's move forward. And now I'd like to invite Professor Chiara Roba. She's a consultant in general and neurointensive care in Genoa, and the deputy chair of neurointensive care section of the European Society of Intensive Care Medicine. So Professor Chiara Roba will talk about how SARS-CoV-2 affects the brain. Thank you so much, Chiara, for being here.
Hello to everybody. I hope you can hear me and see my slides properly. I will start anyway, and you will stop me if you don't. Thank you, first of all, for the invitation. It's really a pleasure, even if unfortunately now we only can meet online, but I hope next year to be face-to-face together again. The presentation that I'm going to face in the next 20 minutes is about the neurological involvement of COVID-19, and I have no conflict of interest regarding this presentation. This is the agenda and what we are going to briefly discuss. I hope to remain within the 20 minutes assigned. So we will start with a bit of pathophysiology as always, and then we will go through the discussion of the clinical presentation and the description of the main neurological complications that can occur after COVID-19 infection. Some ancillary aspects like the use of neuroimaging, neuromonitoring, and then one, I think, very important part, which is the long-term sequela and the neurological outcome and follow-up of these patients. So regarding the pathophysiology, as Paolo was mentioning, SARS-CoV-2 is not just a pneumonia, it's not just an ARDS. We had a bit of fun calling it MODS-CoV-2, so multiple organ disease related to COVID-19, as it really affects not just the lung, but it really affects all the peripheral organs and also the brain. There are different pathophysiological mechanisms which can be associated with the development of neurological manifestations. And in this review, we tried to summarize the main pathophysiological pathways related to neurological complications. We think that there are mainly three different mechanisms. First of all, the viral neurotropism. There is a suspect that there is a possible direct invasion and neurotropism of this virus with the brain. Second, the hypercoagulation and the inflammatory cascade, and then the brain and lung crosstalk. Coagulative and immunological cascade, I think that Dr. Lavinia will go more into details regarding this, but in this nice picture, it's well described that SARS-CoV-2 is able to enter into the brain capillary endothelial cells and can cause basically a process of neuroinflammation with activation of a local microglia and the release of a cytokine storm. And on the other hand, it also can cause an endothelial damage which triggers the formation of microthrombus. And this causes as well a coagulation cascade. And that's the reason why we are really so in trouble when we have to manage these patients, because they have derangement of coagulation, they have a systemic derangement to all the organs and included the brain. Direct neurotropism. there is the suspect that transsynaptic route is a possibility in SARS-CoV-2 infection, because the virus binds to the ACE2 receptors, and there are these receptors in the CNS, so there might be a direct invasion of the neurons, and there are some animal and in vitro studies which demonstrate a direct neuronal invasion, and demonstrate that the virus can replicate within the neurons in vitro. But on the other hand, some authors have also argued about this mechanism, because in most cases the presence of SARS-CoV-2 is not correlated to the presence in the CSF, and is not correlated with the severity of the neuroinflammation and of the clinical presentation. And in fact, neuropathological studies have found that the main mechanism, the main lesions which are present in the CNS in postmortem studies are basically based on hypoxic ischemic injury. And this suggests that one of the major mechanisms for the damage to the brain is mainly related to the systemic hypoxemia. And it's in fact what we have found in a cohort of COVID-19 patients. This is the study that was mentioned before by Professor Paolo Pelosi. We included 22 patients where we explored the relationship between systemic and cerebral oxygenation during rescue therapies, and we found a median cerebral oxygenation of this patient of 52%, which is much lower than the critical threshold, which is generally associated with the development of neurological complications like delirium or cognitive dysfunction, even in the perioperative phase or in non-COVID ICU patients. And we found a direct, very nice correlation between the changes in systemic oxygenation and cerebral oxygenation. So you can imagine that in a condition of so severe respiratory failure, with important episode of hypoxemia, of course, the brain can result damaged. Clinical presentations. When do neurological complications occur? Well, there is not a rule about this. In fact, most of neurological complications occur within the first 14 days. We always have to keep in mind that it's difficult to detect neurological complications because in most cases, these patients are sedated, and therefore we realize that there is a neurological complication when we try to wake the patient up. But so in most cases, cerebrovascular disease occur within the first 7 days. But in some cases, especially cerebrovascular diseases like stroke or Guillain-Barré syndrome, so neurological peripheral dysfunction, can also occur as symptoms at presentation, so before the onset of a systemic or respiratory symptoms in COVID-19. This was one of the first papers which was published regarding the neurological features in SARS-CoV-2 patients. 58 patients were included in this analysis. 84% experienced some neurological signs. And of this, probably the most common was the agitation or the presence of delirium, but also the presence of signs of damage on the corticospinal tract. And some of these patients underwent MRI, and all of them had the perfusion abnormalities in the MRI. Some of them, 23%, 3 cases of up to 13, had also some sort of cerebral ischemic stroke. Most of them were microcerebral ischemic stroke, but some of them also had important strokes. And at the CSF analysis, this is what we mentioned a few minutes ago, no patients had a PCR positive in the CSF for SARS-CoV-2. So no correlation basically between the occurrence of neurological features and the positivity of the presence of the virus in the CSF. After this study, a lot of authors have tried to understand which are the main neurological complications in COVID-19 patients. And in fact, an important number and different types of manifestation, both in the central nervous system and peripheral nervous system, were detected in the last publications. And the risk factors associated with neurological complications were found to be the severity of COVID-19 infection, so the need for mechanical ventilation, the occurrence and the duration of systemic hypoxemia, the age of the patient, pre-existing cardiovascular disease, so again probably an issue with the cerebral perfusion pressure and the delivery of oxygen to the brain, plus specific clinical and patient factors. But in some cases, neurological complications just occurred regardless the presence of comorbidity issues or regardless the age of the patients, so probably related to specific clinical and virus-related factors. We have created in the last year a subgroup of a critical care consortium, which is a very large observational study and group which studies the complications and the different features of COVID-19. And with Professor Sam Hoot, we are leading the neuro part, so the neurological complications related to COVID. And this is a study which came from the effort of this group. We started doing a review and a meta-analysis of regarding the incidence and the type of neurological complications of COVID-19, and we selected the 67 full article studies, where basically we found that the most common features of neurological complications are delirium, for sure, ischemic stroke, hemorrhagic stroke, meningoencephalitis, and also peripheral neuropathies. And regarding, for example, the occurrence of stroke, which is one of the most worrying manifestations of neurological complications, we found a pooled prevalence of stroke of 1.3%. Most of them were in the ICU, so the incidence of stroke increases importantly in those patients who need ICU, going up to 2.8%. And in fact, looking at the whole data of the critical care consortium studies, we found that in a total of 2,600 patients with neurological complications, acute stroke occurred in the 2.2% of this, hemorrhagic stroke in 1%, and ischemic stroke in 0.7%. And if you look at the characteristics of patients with stroke or no stroke, no important difference were found regarding the pre-comorbidities and the pre-functional status of the patients. Of course, there were some important difference regarding the duration of ICU stay and the hospital stay and the outcomes. And some ICU variables were importantly different. In fact, patients who had ischemic or hemorrhagic stroke more frequently underwent mechanical ventilation and ECMO. And looking at the data regarding ECMO, those who underwent ECMO had mainly hemorrhagic stroke, probably because it's related to anticoagulation, and those who did not undergo ECMO had mainly a similar incidence of hemorrhagic and ischemic stroke. And actually not clinically relevant laboratory values in patients who developed stroke were found compared to patients who were stroke-free. We only found an increased risk of hemorrhagic stroke in patients with hypoxemia, but not for the ischemic stroke. And in this analysis, we did not find a significant association between the use of anticoagulant in non-ECMO patients and the development of stroke. So probably is not that common, the stroke in a COVID-19 patient, 2%, although this is still a higher incidence compared, for example, to patients with influenza or other respiratory tract infections. But the occurrence of hemorrhagic stroke was associated with increased mortality, not ischemic stroke, and both were associated with a longer ICU and hospital length of stay. Delirium. This is probably one of the biggest studies which have been published regarding the occurrence of delirium in COVID-19 patients. More than 2,000 patients, really high prevalence of delirium in this cohort, which arrived up to the 70% of the patients. And looking at the risk factors for the development of delirium, actually, the authors did not find important difference with the general population. In fact, delirium is more common in this population, but the risk factors seem to be similar to those in the general ICU population. Like, for example, the age of the patient, higher age is associated with higher risk of delirium. Alcohol and smoke abuse are associated with higher risk of delirium. the need for prolonged mechanical ventilation, the need for prolonged sedation, the need for the use of benzodiazepine was importantly associated with the development of delirium, and the visitation from family and friends, of course, importantly influenced the occurrence of delirium. And in the cohort of COVID-19 patients, one of the issues that we had is that these patients were not in contact with their family and friends. We used to have open ICUs in Genoa, and I'm sure in most of the ICU on the world, and we had completely to change our behavior. Family and friends were not allowed in the ward, and this resulted in an important issues for the patient and healthcare. So regarding the peripheral nervous system disease, just few data are available regarding the Guillain-Barré syndromes. And honestly, looking at the data available, it's difficult to understand whether the incidence and the characteristics are different from the general population. Symptoms and the presentation seems to be very similar. So lower limb weakness and progressive paresthesia. The interval between the development of COVID-19 and Guillain-Barré syndrome seems to be between 5 and 10 days, so maybe slightly shorter than the normal presentation of Guillain-Barré syndrome. CSF in the patients that were explored resulted to be always negative. The presentation seems anyway to be a bit more severe, more progressive, and axonal injuries were more frequent in the patients with COVID-19. But it's very difficult with just a few case reports to understand whether this is specific for COVID-19 patients. And the same is for myasthenia gravis. We observed a high number of exacerbation of myasthenia gravis, which can contribute or be the cause of respiratory failure. And in this very nice review, the authors basically described all the cases of exacerbation of myasthenia gravis in COVID-19 patients, and they supposed two main mechanisms regarding this increased number of myasthenia gravis crisis. One, the autoimmunity, and the second is the respiratory interplay between the virus and myasthenia gravis. Regarding the first point, SARS-CoV-2 may actually trigger and amplify the autoimmunity process which is present in myasthenia gravis, because it shares amino acid sequences with host components, which results in the cross-activation of T and B cells. And this is promoted directly by the COVID-19 patients. So this can be a specific mechanism related to COVID-19, but there is also, and I think this is one of the major component of this issue, the respiratory interplay between SARS-CoV-2 and myasthenia gravis, because if you consider that the occurrence of SARS-CoV-2 can induce hypoxemia, vagal activation, increased physiological dead space plus an increase of emotional response, you have, of course, a reduction in the respiratory drive activation, which basically results in an increased respiratory muscular load, which develops a myasthenic pattern with reduced fatigue threshold, and this can cause a progressive reduction in the pressure which is produced by a diaphragm, and therefore hypoventilation and myasthenic crisis. Other aspect, very briefly, neuroimaging. A large number and type of neuroimaging features have been described in COVID-19 patients. This is a systematic review of more than 100 patients. Among these, 90 patients were at the CT positive, but basically most of the CT findings were aspecific, so microhemorrhages, and the 31% of these patients had neurological signs but had no CT abnormalities. And this makes us think that maybe CT is not so precise to assess the presence of fine and small alteration, especially regarding the cerebral blood flow. And therefore, the group of Cambridge, led by David Menon and Virginia Newcomb, they did, I think, a great job producing this paper, which was published on ICM. They did a quantitative DTI, and basically they demonstrated that in the gray matter regions, COVID-19 patients compared to controls have a higher incidence of vasogenic edema, and in the mesencephalic and in the pons areas, these patients have an increased area of cytotoxic edema. And at the histologic assessment, these patients also have a very important parenchymal infiltrate of T cells, which represents the inflammatory cascade related to COVID-19 patients, and the involvement of the cortical and of the hippocampal area can actually explain the presence of cognitive dysfunction and long-lasting mental alteration as well as delirium. Neuromonitoring, is it useful? Well, I think so. This is one of the very few papers which were published regarding the use of neuromonitoring. Of course, we are talking about non-invasive neuromonitoring because these patients are not primarily brain-injured patients. And these data come from our group. In our cohort of patients, we found an increase of intracranial pressure in nearly the 40% of the patients. And this could be related to different factors, the issue itself, so the presence of cerebral edema, but also our treatment, because when we use lung protective strategies, IPEEP, recruitment maneuvers, prone position, etc., we can actually increase the risk of intracranial hypertension. And interestingly, we found that the presence of increased intracranial pressure had no effect on hospital length of stay, but was associated with a higher and prolonged ICU stay because of the presence and occurrence of delirium and a delay in the awakeness of the patients. And finally, I think that the last point that we need to touch, which is very important, is the presence of long-term neurological sequelae. COVID-19 has been described as a brain fog because a huge number of patients experience long-term post-COVID symptoms that follow up. This is a short-term follow-up, one of the first papers published. Within 1 month, the 87% of the patients had persistent neurological symptoms. This is an example of a more longer follow-up, 110 days after admission, and again, an incredible high number of patients who still had attention disorders, memory loss, sleep disorders, and importantly, which is what we care in the ICU, many of these patients were not able to go back to their previous life. Work, sport, quality of life was not back as previous the ICU admission. And this is probably the biggest paper which has been published on COVID-19 regarding 6 months neurological and psychiatric outcomes. And what interestingly the authors did was to compare the risk of neurological and psychiatric outcomes between COVID-19 and other respiratory tract infections, like, for example, the influenza. And patients with COVID-19 had an importantly higher risk of ICU intracranial hemorrhage, ischemic stroke, peripheral nervous dysfunction, and long-term sequelae like dementia, mood, anxiety, and psychotic disorders and neurocognitive disorders. So COVID-19 shares some pathophysiological mechanism with respiratory tract infections, but probably there is something more in COVID-19 which is probably explained by the pathophysiological mechanism that we have discussed. So in conclusion, there are different clinical phenotypes of neurological manifestation, which unfortunately are very, very common. The pathophysiology is likely to be multifactorial. Some factors are specific for COVID, some factors are not specific for COVID, but are generally similar to those for other ICU patients. Stroke is probably not as frequent as we thought at the beginning of the pandemic, but it strongly influences the outcome. And I think that we really need to put a big effort on the evaluation of the follow-up of these patients, because we save lives, we discharge the patients from the ICU, but after 6 months, 1 year, these patients do not come back to their normal life. And that's where we still have to fight and work a lot. Thank you very much for your attention.
Thank you, Chiara. Excellent talk. I'm very proud. And let's move forward. And I'd like to introduce Andrea Lavigno. Dr. Andrea Lavigno is a consultant neuroscience and trauma critical care unit in Cambridge University. He will talk about coagulative disorders in COVID-19. Thank you, Andrea, for being here.
Thank you, Professor Rocco, for the invitation, and it's a great pleasure to be here and to present after Professor Pelosi and Professor Roba. It is a great honor to be here. Coagulative disorders in COVID-19 is a topic that interested all the clinicians that were directly or indirectly involved with the care of patients that came to our hospitals with moderate or severe illness. I have no conflict of interest to declare regarding this, but I need to put my hand forward and admit that this is a huge, huge topic, and that I won't be able to cover all aspects of it in the time allocated to this. For those that have interest in the details, there are a number of recent reviews on the pathophysiological aspects that we'll brush upon today on Nature and the New England Journal of Medicine. So we will only touch upon them very briefly, as we will on the prevalence, the risk factors, and how we have been monitoring the severity markers that somehow predict patients that will develop the thromboembolic complications. And we'll very briefly mention the pharmacology of the anticoagulants and antiplatelet agents, and their variable ability to immunomodulate the host response. And particularly, I think it needs to be pinned for those that want to go back and look at this pharmacology in more details, is the interaction with the ACE system. And the reason why I would suggest that heparins, low molecular weight heparins and unfractionated heparin, perhaps had the best chance of providing a degree of protection against the thromboembolic complications triggered by the virus-host interaction. But obviously there will be one of the key points I'll try to highlight is the safety profiles of these agents. The main corpus, and I think what I have to offer to the listeners today, is the perspective of someone who's been directly involved with the care of these patients in critical ill COVID patients. And therefore, I'll try to give you my interpretation of the evidence and how the evidence has translated to clinical practice and outcomes over the past couple of years. Another topic that in itself would probably cover the best part of an hour is the thromboembolic events, and in particular, obviously, cerebral sinus thrombosis related to vaccines, or the AstraZeneca vaccine in particular. Obviously, these are events that occur in one case every several 100,000 of vaccinated patients, but they can be life-ending, if not life-changing. And because we look after a cohort of a population of 5 million, we've had our share of these patients. But we won't be able to touch upon this with any detail, and perhaps we'll have time to discuss this during the discussion. So we said it's a very complex interaction, immunothrombosis, an imbalance of the ACE system with an excess of ACE2 inhibitors, endothelial damage, inflammatory process that occurs in the alveoli, and that precipitates pulmonary thromboembolism in a great majority of those that die, or if not the totality of those that die of COVID-19. But also arterial thrombosis with myocardial injury, stroke, it's at about 2%, 1%, as Professor Robert just discussed, and a very, very high incidence of deep vein thrombosis of unclear clinical significance. This is reflected in patient bloods with very increased D-dimer and very much increased fibrinogen in a way that I personally had not seen in 15 plus years of critical care experience. And when you would draw blood from these patients for big lines, the appearance of their blood is that of jam, and it would form clots under your eyes. So there is a component of these pro-inflammatory markers that you are probably very familiar with, but also, and that renders not only the endothelium, but the blood itself very prone to rapid clotting. And we knew that our standard strategies were not working. So our standard approach of 40 milligrams dalteparin would still result in ICU. If you are looking for it, you would find DVTs in the vast majority of patients. For us, in our ICU, despite a very careful pharmacological prophylaxis, we would still have clinically significant thromboembolic events in about a third of our patients. So most of the units in Europe, based on this observation, increased treatment to an intermediate or prophylaxis, I should say, to an intermediate dose, which is essentially twice as much. So rather than 50 units per kilogram per day, we doubled that. Some units went on to full anticoagulation, but there was quite a lot of resistance. And we did that on the grounds that we knew that these doses of patients, these doses of thromboprophylaxis are very, very safe and associated with a relatively small incidence of bleeding. On the face of these patients that were coming in our CU, when 1 or 2 of them approximately was dying at the time, and 1 in 3 would die of massive pulmonary embolism, essentially. And there had been reports early on that thrombolysis would reverse critical deterioration. So we started doing that. And I'll go to the last slide to make sure I cover this. Essentially, this is based on very robust evidence. Any patients that's confirmed to have COVID that requires oxygen therapy, non-invasive oxygen therapy, should be started on therapeutic anticoagulation. My interpretation of the evidence, although not all guidelines are interpreting this in the same way, but I'll try to make this point, and I'll use most of my time to make this point, is that anticoagulation should be started at therapeutic doses on admission and continued even if the patient deteriorates and is admitted to an ICU. For those patients that are admitted directly from home to the ICU, which I think is a fairly rare event, I think it would be fair to start an intermediate dose of anticoagulation. And the last point, that depending on what your practice is that anticoagulation at therapeutic doses should be delivered or provided using low molecular weight heparins rather than unfractionated infusions. We'll talk about this in details, but unfractionated heparins are risky in the context of a COVID pandemic. They require numerous contacts between healthcare providers and patients, monitoring, and this is prone to titration errors, despite the fact that it is resource intensive. And for those, and we're talking about perhaps close to 2%, that develop heparin-induced thrombocytopenia, then fondaparinux should probably be the next agent to be used. So this is pretty much all of the lecture, and I'll argue how we come to that conclusion. We started, as we say, giving this intermediate dosing and across Europe very early on. We're talking March, April 2020. And thanks to Professor Roba, we did this observational report with about 1,000 patients, where we were finding that thromboembolic events were still extremely high, about 20%, so close to half compared to what we are having before the increased dosing. and that mortality was in 40% of these patients, which is what had been reported across units in North America and Europe at that time. And unfortunately, it's still very similar in our ICU population, which is primarily not vaccinated. And what I would like to point to is that we moved from 30% to 20% or close to 15% of thromboembolic events, that our patients are, for the great part, 30% clinically obese. And we did not see any increase in hemorrhagic events and a clear association with improved mortality. There was a bit of a cold shower that this was published this March 2021, when in 600 patients, the INSPIRATION trial says there is no difference between standard dose and intermediate dose, so we recommend standard dose. This is in Iranian ICUs. Effectively, they say the outcomes are identical. We should keep with the standard practice, and these triggered the discussion in our institution, and we were finally successful in convincing that we should not move away from the enhanced dosing, and in fact we later on implemented a full therapeutic dose. And the key is in the detail here. If we look at the incidence of thromboembolic events in these two arms, they have an incidence of about 3% in this study, with a very young, very lean patient population that does not reflect the characteristics of any of our ICUs. So in our ICUs, where your incidence, where your baseline incidence or expected incidence of thromboembolic events is around 30%, you should provide offer these patients prophylaxis at therapeutic dosing with low molecular weight heparin, I would insist. And then big studies came out, a collaborative platform between Attack Active and REMAP-CAP, and they gave us this definitive answer that if you start therapeutic anticoagulation when patient is admitted, you will reduce mortality and the organ support 3 days. And I would like to point you to this aspect, that of these 13,000 patients that had been screened, already 15%, 1 in 6, or more than 1 in 6, were already diagnosed with a thromboembolic event that had occurred and had to be started anyway. So this is in patients that have no clear indication for anticoagulation. When anticoagulation is started, this results in improved outcomes. And this is the way the group represents the data. And the dark blue essentially represents a score where the patient is never admitted to ICU. And we see in these patients is about 80%. But in these faded colors, -1 is death. And this is faded colors is patients requiring organ support. And these are patients that end up being in ICU, and probably the patients where the divide between outcomes occurs. And these patients, when they were transferred to the ICU, continued to receive therapeutic anticoagulation. And again, we see another essentially halving of thromboembolic events. This is for moderate, so the non-initially admitted to ICU, where the thromboembolic events or death composite drops to 8%, with thromboembolic events going from 2 to 1%, and major bleeding doubling in the full therapeutic anticoagulation. Unfortunately, there is no subgroup analysis for low molecular weight heparins and unfractionated heparins at this time, but I would be interested, and I'll be in contact with the authors to find out what the details are. And if we look at the data, this is interesting, there is a very, very strong gender effect. So most, if not all, of the beneficial effects of therapeutic anticoagulation is in the male subgroup. This is in excess of 2,000 patients enrolled in these studies. Very few of these patients in the moderate group received unfractionated heparin. We see this is very different compared to the ICU study. And this reflects practice on the general ward where heparin infusions are rarely used. And we see that because this study reflects, and the protocol design reflects practice at the time, a quarter of these patients that we are comparing it to is compared to intermediate dose thromboprophylaxis. So therapeutic low molecular weight heparin is essentially 4 times the standard dose. Intermediate is 2 times the standard dose. And there clearly is a benefit when increased from 2 times the standard dose to 4 times the standard dose for prophylaxis. Again, this is an excerpt from the protocol where we see that the group continued with therapeutic anticoagulation when the patient deteriorated and went to the ICU, and that was continued at least until the patient remained on mechanical ventilations. So that's the take-home message, which for the first half has been incorporated by I practice in the UK by NICE guidelines. So if you come in, you need oxygen, you're started on prophylaxis at therapeutic dose, so 4 times the standard dose. But then therapeutic anticoagulation should be continued even if the patient deteriorates and need organ support. And this is controversial. This is controversial because the second publication, they came out at a slightly different time, the announcement, looked at patients that were admitted to the ICU. And these patients, ended up being half the size. And of the 13,000 patients, the vast majority were excluded, and a big chunk of these were excluded because they were already on anticoagulation. And essentially, they found no difference in mortality, but an increase in a non-significant signal towards harm, but a doubling of hemorrhagic rates from 2% to 4%, essentially 2.3 to 3.8%. And this is the data presented in the same format as before. You see up there that the cumulative proportion is very similar, but effectively there is an increase in hemorrhage. And again, there is a very strong gender effect, and it looks like that most of the harm occurs in females. So especially for male patients that come to ICU, what I will say next will be doubly important. So one of the key point I would like to highlight is that in the so-called usual care, the vast majority of these patients were already receiving intermediate or full therapeutic low molecular weight heparin. So we are effectively seeing 2 groups in which both groups are receiving enhanced thromboprophylaxis. And the authors recognize this in their observation. So the other difference that we see is that unfractionated heparin was used in a big chunk of the therapeutic dose anticoagulation compared to a 1% in the pharmacological thromboprophylaxis. Also, there is another important difference, is that subtherapeutic dosing, and I suspect this is closely related, these 2 points, happened in almost 10% of patients that were therapeutically anticoagulated compared to less than 2% in those that were on the usual care. But the key would be is that the usual care ICU, for 60% of these patients, are receiving intermediate dose prophylaxis or therapeutic dose prophylaxis. So the group separation is not that obvious. The main difference is that in this group, they're receiving unfractionated heparin for a grey pulp. And there is a problem that we have seen on several occasions with unfractionated heparin. If you have an hypotensive crisis in an overcrowded ICU, you have insulin unfractionated heparin running, and you might have multiple pumps running at 2 mL an hour. And you say, titrate up the noradrenaline. It's the one going at 2, and you have a nurse that's there. Yesterday she was on a urology ward. She cranks up the 2 mL an hour, not realizing that it's unfractionated heparin. And then a sample is not sent. Several hours go by. And either overdosing or underdosing is very, very likely to happen. And I'm not at liberty to disclose the results of this large observational study, which had enrolled about 5,000 patients. But when we looked at that, and this again is implementation of day-to-day practice in our ICU, we saw a threefold increase in hemorrhage, critical hemorrhage in therapeutic unfractionated heparin compared to therapeutic low molecular weight heparin, but also a doubling of thromboembolic events in unfractionated heparin compared to therapeutic low molecular weight heparin.
Gustavo, 1 minute?
Yeah, sure.
Okay, thank you.
We see that thromboembolic events were reduced in both arms compared to historical data, and the separations is not great. So the conclusion is that therapeutic anticoagulation should be continued and should be continued using low molecular weight heparin in patients that deteriorate to ICU level of care. Thank you very much for your patience.
Thank you, Andrea. Excellent talk. Now we know everything about the coagulation disturbance. And we have several questions for you, of course. And let's move forward. And I would like to introduce Professor Celso Caruso. Professor Celso Caruso Neves is full professor at Federal University of Rio de Janeiro, and he has a great expertise in renal physiology, and he has been worked hard in COVID during this period of pandemic. And today he will talk about the kidney damage induced by SARS-CoV-2. Professor Caruso, please.
Okay. First of all, I would like to say thanks Dr. Patricia Rocco for this invitation. She's a great friend. She's a great collaborator. Thank you very much. Today I will talk about the molecular mechanism underlying kidney damage induced by SARS-CoV-2. Nowadays, the severity of COVID-19 is associated to multiple organ injury. In this context, today we will talk about the role of kidney damage in development of severe COVID-19. Here you can observe 3 different studies showing the incidence of acute kidney injury in COVID-19 patients admitted intensive care units. This incidence could range from 20% up to 53%. Here we can observe that the COVID-19 patients that develop acute kidney injury has higher mortality rate when compared with those that did not develop acute kidney injury. These observations highlight the role of kidney injury in the development of severe COVID-19 and the worst outcome of these patients. What's the possible cause of kidney injury in COVID-19 patients? Several hypotheses have been postulated. The first of them, it has been postulated that the inflammatory cytokines and immune cells could act directly in the kidney, promote the kidney damage, and consequently development of acute kidney injury. In another hypothesis, it has been proposed that hemodynamic instability caused by damage in the heart and the lungs could lead to ischemic tubular injury and the consequent development of acute kidney injury. And the last one, it has been shown that the glomerular and tubular cells are directly infected by SARS-CoV-2. This infection causes tubular and glomerular damage and consequently promote the development of acute kidney injury. In this talk, we will discuss the role of the infection of these cells, the glomerular and tubular cells, mainly tubular cells, by SARS-CoV-2, and the possible mechanism involving tubulointerstitial injury. This is a very interesting graphic. Here you can see the correlation between the severity of COVID-19 and the development of acute kidney injury. In blue, you have the less severe COVID-19, and in pink, you have more severe COVID-19. And you can observe before the development of acute kidney injury, there is an early phase called the subclinical acute kidney injury. In this early phase, there is no change in creatinine, in plasma creatinine, and glomerular flow rate. But it's possible to observe proteinuria, mainly characterized by low molecular weight proteinuria, albuminuria, and hematuria. This subclinical phase is associated to tubulointerstitial injury. And so, looking at this graph, we can imagine that if we understand the mechanisms involving tubulointerstitial injury, we could halt the progression to acute kidney injury. So, in agreement with this possibility, wearing co-workers made post-mortem examination in 6 patients with COVID-19. They observed the acute tubular injury in these patients. Furthermore, they observed that the high prevalence of proteinuria and albuminuria in these patients, and mainly I would like to call your attention to the increase in urinary excretion of beta-2 microglobulin. It's a marker of tubular injury. So, we can conclude that these results indicate that these patients have tubular proteinuria. Tubular proteinuria is associated to megalino-mediated protein reabsorption proximal to the cells. The protein reabsorption proximal to the cells involve a receptor-mediated endocytosis, where megalino plays an important role to the internalization of the protein. Once internalized, protein is degraded in lysosome, and the amino acids secreted in basolateral side. Several groups, including our group, has proposed that change the albumin-endocytosis machinery in proximal tubule cells are involved in genes of tubulointensial injury. In agreement with this proposal, wherein co-workers observed that the COVID-19 patients has lower expression of megalino involved in albumin-endocytosis and protein endocytosis in proximal tubule cells when we compare with healthy individuals. So, based on this observation, we created the following hypothesis. SARS-CoV-2 could induce change in proximal tubule albumin-endocytosis machinery, leading to tubular injury, albuminuria, and consequent development of subclinical acute kidney injury, an early phase preceding acute kidney injury installation in COVID-19 patients. To test this hypothesis, we used 2 cell lines, the porcine renal proximal tubule cells and the human embryonic kidney cells, and we did not use virus, not infection with virus, but we used the spike protein. Spike is the protein responsible to bind to ACE2, the receptor for the SARS-CoV-2, and the binding of spike protein to ACE2 promote the internalization of the virus and the infection of the cells. As our experimental design, we incubate the cells with spike protein for 2 or 16 hours, and the cells were washed out, and the experimental procedures were carried out. In the first results, we can observe the effect of the spike on the albumin endocytosis in LLCPK cells and the HEK cells, 293. The incubation of the cells for 2 hours with spike protein did not change albumin endocytosis in both cells. But, interesting, the incubation for 16 hours provoked significant inhibition of albumin endocytosis in both cells. Here, we use the immunofluorescence to study the effect of the spike on the albumin endocytosis. In red, you can see lectin, the marker of plasma membrane, and in green, you can observe the albumin FITC. It is clear that the spike protein could decrease albumin endocytosis in both cells. Here, we use the effects analysis to also study the effect of the spike protein on the albumin endocytosis. Again, we observe that spike protein decreases the albumin endocytosis in both cells, LLCPK cells and the HEK cells. So, now we decide to investigate if the spike could change the albumin degradation lysosome. To answer this question, we use DQ albumin, a marker of protein degradation lysosome, and you can observe that spike protein decreases the albumin degradation lysosome in both cells. These results is very similar to those observed when we measure the albumin uptake. So, now we decide to investigate if the effect of the spike in fluid phase endocytosis what corresponds to specific albumin endocytosis. For this, we use the strand FITC, and here we can observe that spike did not change the strand uptake, indicate that spike did not change fluid phase albumin endocytosis. And here we test the effect of the spike in the expression of aquaporin 1, water channel, constitutively expressed in proximal tubule cells, and the spike protein was not able to change its expression, showing the specificity of the effect to albumin endocytosis. So, take these results, you can take the first conclusion, where spike inhibits the canonical megalino-mediated proximal tubule albumin endocytosis, and this effect could be correlated to albuminuria observed in these patients. Here you have the scheme showing the effect of the spike in the canonical albumin endocytosis in proximal tubule cells, And I would like to call your attention that this effect agree with those observed in patients by Warren and co-workers. The proteinuria, albuminuria, and the increase in the urinary excretion of beta-2 microglobulin. So what's the mechanism involved in the inhibition of proximal tubal albuminoglycocytosis induced by spike? Again, I would like to call attention to the megalin role. Megalin is important, is a receptor involved in internalization of the albumin, so we decide to test the effect of spike on the expression of megalin, just as it was observed in patients. Here we use the immunofluorescence. In green we can see the megalin, and in blue we can see the nucleus. And the spike protein promotes the decreased expression of the megalin in both cells, LLCPK cells and HEK cells. Again, we use effects analysis to measure the megalin expression, and we also observe that megalin expression was decreased in both cells induced by spike protein. So, answer for our question, spike decrease megalin expression. The decrease in megalin expression promote the decrease in albuminoglycocytosis. And again, these effects, these results are in agreement with those observed in the patients. Here, I would like to call attention again, the bind of spike protein to ACE2, what promote the internalization of the virus and the infection of the cells. So based on these results, we decide to study the involvement of ACE2 in the effect of the spike on the albuminoglycocytosis. First of all, we decide to measure the expression of ACE2 protein in LLCPK1 cells and the HEK cells. Both cells express ACE2, but the expression in HEK cells is higher when compared with LLCPK cells. In the lower figure, you can observe that the spike protein did not change the expression of ACE2 in both cells. And here we measure the spike uptake in both cells. We can observe that both cells were able to uptake spike, but the spike uptake was higher in HEK cells when compared with LLCPK cells. These results, very similar results when we measure the expression of ACE2, indicate a strict correlation between the expression of ACE2 protein and the spike protein uptake. Here we decide to investigate the spike protein using immunofluorescence in LLCPK cells, in HEK cells. In red, you can observe the expression of ACE2, and in green, we can observe the spike uptake. In HEK cells, it's very clear that there is a co-localization between spike and ACE2, but this co-localization is not so evident in LLCPK1 cells, indicate that the other protein could be involved in the spike protein in these cells. These results agree with previous observed that spike protein uptake in LLCPK cells is mediated by KIM1 protein, is another receptor. It has been postulated. Only to remember you, the ACE2 is able to break down angiotensin 2 in angiotensin 1-7. Angiotensin 2 promotes pro-inflammatory and pro-fibrotic response, and these effects are mediated by AT1 receptor, while angiotensin 1-7 has contrary effects to angiotensin 2. Angiotensin 1-7 induces anti-inflammatory and anti-fibrotic response, mediated by MAS receptor. So it has been described that spike protein could inhibit ACE2, and this inhibition could enhance the pro-inflammatory and pro-fibrotic effects induced by angiotensin 2. So, looking at this scheme, we decide to investigate if spike protein with the effect of spike protein on the albuminoglycocytosis could be mediated by components of the renin-angiotensin system. So, in the next one, before to answer this question, we test the effect of the spike in another protease called the prolyl carboxypeptidase, the component of the renin-angiotensin system, that has the similar effect of ACE2. PRCP break down angiotensin 2 in angiotensin 1-7. And we could observe that the expression of this enzyme is not changed by spike protein. Now, we decide to investigate the level of angiotensin 2, the indirect measure of the activity of ACE2 and PRCP. And you can observe that we could observe that spike protein did not change the secretion of angiotensin 2 by these cells. Furthermore, the inhibitory effect of spike protein on albumin endocytosis was not changed by H1 receptor antagonists, H17 receptor antagonists, or H2 receptor antagonists. So the answer for our question is the inhibitory effect of spike on proximal tube albumin endocytosis mediated by renin-angiotensin system. The answer is no. So what could be the molecular mechanism behind the inhibitory effect of spike on the albumin endocytosis in proximal tubule cells? I bring this interesting scheme where there is where we can see the strict correlation between AKT, called the protein kinase B, and the albumin endocytosis in proximal tubule cells. Here you can observe that when AKT in active form, there is the decrease in that megalin expression, consequence decrease in albumin endocytosis. When AKT is activated, there is the increase in the megalin expression and decrease in albumin endocytosis. On the other hand, the increase in the albumin endocytosis promotes the activation of AKT, while the decrease in albumin endocytosis promotes the inhibition of AKT. AKT activation occurs by phosphorylation of two specific residues, threonine 308 located in activation loop, and serine 473 located at the hydrophobic domain. The phosphorylation of both residues promote the full activation of AKT. So, looking at this scheme, we decide to investigate if a spike could modulate AKT activity. Here we can observe that the phosphorylation of AKT at serine 473 was not changed by spike in both cells, but very interesting results, the phosphorylation of threonine 308 was decreased by spike in both cells. So, based on these results, we propose that spike lead AKT to an intermediary state where it is phosphorylated at serine 473, but the phosphorylation at threonine 308 is inhibited. This intermediary state is promote the inhibition of AKT activity. To measure AKT activity, we use the specific substrate GS-P3-beta, the specific substrate. AKT was described to phosphorylate specifically serine 9. Here you can observe that the phosphorylation of serine 9 is decreased by spike protein, indicate that the spike is able to decrease AKT activity. Phosphorylation of threonine 308 is mediated by PDK1, which is inhibited by staurosporine. So we decide to determine if staurosporine could mimic the effects of spike on the albumin endocytosis. Here you have the control condition where we test the effect of staurosporine on the phosphorylation of serine 473 and threonine 308. And we observe that phosphorylation of serine 473 was not changed, but phosphorylation of threonine 308 was inhibited. Furthermore, we observe that staurosporine decreased the albumin endocytosis in a very similar way to observed with spike protein. 2 minutes
1 minute,
more, okay?
Professor Carolus.
Okay, only a minute. Here we test the effect of the spike on the ERK1/2 activity, the another kinase involved in modulation of albumin endocytosis across multiple cells, and we observe that spike did not change the activity of ERK1/2 in both cells, indicate the effect of the spike is specific to AKT pathway. So, based on these results, we can take two main conclusions. The first one, modulation of canonical megalin-mediated albumin endocytosis in proximal tubule cells by spike could be one of the mechanisms behind tubular cell injury observed in severe COVID-19. Here you have the scheme that we reach with our results. Spike decrease AKT activity, decrease promote decrease in megalin expression, and decrease in albumin endocytosis. These effects are very similar to those observed with the patients. But so far, we did not establish the correlation between albumin endocytosis and tubular injury. And we have some preliminary results I would like to show you. The spike induced the secretion of pro-inflammatory cytokines, TNF-alpha, and IL-6 in LLCPK1 cells. It's very common. This pro-inflammatory cytokines is common in COVID-19 patients, as well in tubular injury. Furthermore, we observed that spike decrease induced the necrosis in proximal tubal cell lines, and these results agree with previous has been described to COVID-19 patients. I would like to remember that COVID-19 have revealed acute tubular injury characterized by most mild focal acute tubular necrosis. And as a second conclusion, with spike protein isolated triggers cellular response and modulates cellular function. In agreement with our results, it has been observed spike protein in the urine of COVID-19 patients, and furthermore, some authors have shown that spike could induce modulatory effect in monocyte and macrophage, inducing the secretion of IL-6. So the idea that intact virus could induce COVID-19 pathogens could be enhanced, since we have shown that spike protein could promote renal tubular damage, and it could be also involved in COVID-19 patients. These results, I would like to leave a message. This observation opened the possibility that viral protein fragments could play an important role in pathogens of COVID-19. Here, I would like to say thanks to the main collaborators, the guys that developed these studies, Rodrigo, the PhD candidate, Diogo, postdoc, and Douglas, master student, the other member of my lab, to say thanks to the financial support and say thanks to the audience. Thank you, everybody.
Thank you so much, Celso. Great talk, very attractive data. And I'd like to ask some questions to all of you. And please answer in a way very objective, since we have several questions in the chat. And the first one is to Professor Andreas. And the question is, thank you for your talk. You showed the sex difference on coagulative disorders. There is also a gender effect on the effectiveness of the treatment protocol. This is a very important data, because we found that indeed not only related to coagulative disorders, but also disorders has been associated with gender. And why do you think we have this kind of difference between male and female? And are coagulative disorder present in post-COVID and long COVID?
So the difference is probably, it's not reflected in bloods that we would, or in factors that we could identify in the normal battery of tests that, despite those being fairly comprehensive. But they're probably related to differences in the ACE system. But to clarify, the difference is exactly a difference in response of treatment. So the treatment seems to benefit particularly males in excess of females. So it's not really an issue of prevalence. Thromboembolic events occur in both male and females, but the clinical manifestations of severe COVID-19 tend to be more severe in male for a variety of reasons. And the anticoagulation seems to be particularly protective in this group of patients. In terms of long COVID, the incidence of thromboembolic events after the acute phase goes back to normal, to that of baseline. Obviously, we have patients that have reduced mobility due to the neurological manifestations that Professor Rob outlined earlier. So in those patients, obviously, they would have generic risk factors for that. And I would say the other coagulation disturbances in out of hospital setting would be related to complications, very, very rare complications associated with vaccination.
Oh, yeah. This is a huge problem that we are facing with some vaccines,
Yes,
that
so
we have more thrombotic events compared to the others.
So for the AstraZeneca vaccine, which is the kind of the flip side of it all, is that especially in young females, but we are talking cases of a few units in a million patients vaccinated. We have cerebral sinus thrombosis, which is an extremely rare event. But I would say, to state very clearly, the incidence of even cerebral sinus thrombosis, or the risk of that, is much higher if you contract COVID naturally. So it's not an indictment to be more cautious about the vaccination. But I would say in young females, obviously Pfizer, if you're a female who's younger than 40, and perhaps have other risk factor like the contraceptive pills, which has by itself a risk of thromboembolic events that is in the 1,000 times higher than the risk associated with the vaccine, then you would choose Pfizer or Moderna rather than AstraZeneca.
Okay. I have a question to Professor Caruso Neves. Professor, you talk about the magazine, and I'm so interested in this.
Sorry, I can't hear you.
I'm asking you a question related to magazine. Can you hear me now?
Yes, now I can hear you.
Okay, so this is a very interesting protein that it's not very usual to be measured, and it seems that we may have an early diagnosis if we measure magalin. What's your opinion related to this issue? Because we are usually measuring urea, creatinine, and this magalin, it's so interesting. What do you think about this issue?
Thank you for your question, Patricia. Magalin has been described to be excreted in the urine. So some guys are looking for the possibility that the magalin excreted in the urine could be a marker of early tubular injury. So it's not determined, but it's a possibility, because the magalin has an extracellular domain. It is proteolytic. It's breakdown and released in the urine. So some guys believe that this proteolysis occurs during the installation of tubular injury, but there is no study correlating this with the progression of a renal disease. Let me tell you one thing. Now in my lab we are working with PRCP in urine, and we can be observed that the early excretion of PRCP is a good marker for acute kidney injury. So we didn't publish these results, but besides magalin, I think PRCP could be a better marker of a tubular injury, and you can diagnose the tubular injury in the early phase of acute kidney injury. In my opinion, PRCP is better than magalin in urine.
Yeah, absolutely, because we needed to know earlier markers.
Yes.
This is my question to Chiara, because Chiara, I thought that there are more important mechanism, and then you told us that hypoxia is so important. I thought that the virals, the systemic inflammatory process are the most important mechanism for the brain damage. And then you told us, okay, you have to focus on hypoxia. This is very, very, very important. Tell me how to prevent this brain damage.
Oh, this is a $1 million questions. So I would say that Professor Pelosi mentioned that there are two types of hypoxia, the happy and the unhappy hypoxia. I would say that for the brain, hypoxia is always unhappy, because whatever is the reason, whatever is the pathophysiology, secondary brain damage is directly correlated to the systemic hypoxemia. So, as I was mentioning, I think that there are some mechanisms that are shared between COVID and any other respiratory tract infection, like mechanical ventilation strategies, the hypoxia, etc. And then in COVID-19 patients, these are even much exacerbated by the coagulative disorders, the immunological issues, etc. So it's a combination of factors, but actually what we can really work is the systemic oxygenation. We know that cerebral oxygenation depends mainly on hemodynamic stability, on the delivery of an appropriate cerebral perfusion pressure, and on the maintenance of systemic oxygenation. This is what we have seen in the study that Paolo has presented, where Patricia, you were also one of in the team. We have seen that, for example, during recruitment maneuvers, even if you can increase the systemic oxygenation, you have a decrease in arterial blood pressure. So at the end, you have a reduced cerebral oxygenation. So it's very complex and it's not easy because I can tell you that to prevent secondary brain damage, you have to avoid hypoxemia and hemodynamic instability. But how can you avoid systemic hypoxemia in such severe respiratory failure like COVID-19? So it's very, very difficult. So you have to play between the hemodynamic and respiratory status to help the brain to maintain its physiology.
Yeah, I fully agree with you. And Professor Pelosi, I have a $1 million answer for you. This is $1 million question. You know that the different phenotypes, every time that we decide to do everybody try to ask us how to define this different phenotype. And we are always focused on the CT scan. But physiologically, we know that we are able to evaluate these different phenotype based on the lung physiology. And since this is a meeting where we have several physiologists, pathophysiologists, and immunologists, tell them at the bedside, without the CT scan, how to evaluate these different phenotypes.
Thank you, Patricia. Yes, first of all, to clarify something that sometimes is misunderstood. The two or three, whatever, different phenotypes does not mean that these are two different etiopathogenetic entities. In our opinion, in my opinion, this is just the evolution of a type of the disease towards the improvement, towards the progression or worsening or stabilization first. So it are not different things, but are the same things from two other side of the coin. The second point is how to do how to have information from clinical point of view. Well, from imaging, I remember that in my opinion, lung ultrasound may give very clear information. Because if you put a probe in the most dependent part of the lung, in the most phenotype 2, what I presented here, and 3 in our original paper, but I tried to simplify. Yes. We have white areas, and these are clearly seen. We find not much in COVID-19 pleural effusion, so clearly seen hyperechoic areas. While in the phenotype 1, we can have some B lines, A lines, but much less hyperechoic. And I remember even there, the B lines, in my opinion, I know that there are many experts in lung ultrasound, but the B lines in COVID has nothing to do, zero, with the B lines of the conventional lung ultrasound, as commonly written by experts. Because the B lines usually in the traditional echo are due to the increase in the interstitial edema. We have seen also that in animal experiments, because it's the traditional RDS. Here, the B lines are just the evolution in what I showed, the ground glass areas, which are partially aerated with low VQ areas, and this is nothing to do with edema. So if you have an increase in B lines, we have not to give diuretics, in my opinion, but to keep a good balance, of course, to avoid overfluids perhaps, but in COVID-19, B lines, in my feeling, is nothing to do with the interpretation of cardiac edema or traditional RDS. Third point is gas exchange. Our data and our model, that to me is the model of COVID-19, unless others can, I mean, of course, everyone is open for discussion, but we have to measure aeration and perfusion, not partially one or partially the other in the whole lung. When you deteriorate, so when oxygenation does not, I mean, when saturation stays not above 88, 92%, with 60, 80% of oxygen, this means that the patient is moving to phenotype 2. And in my opinion, of course, there's a huge discussion. We should intubate the patients unless there are other organizative problems and does not permit. But not to keep the patients breathing with whatever non-invasive respiratory system for a prolonged period of time. I can say more than 2 days. If the patient do not improve, if they improve, okay. So sometimes I am misunderstood from some people that but all you say that you have to intubate everyone. No, I'm not saying that. I'm saying that if you improve, okay, you have to continue. But if you don't improve or even you deteriorate in oxygenation, which is a simple parameter, then we can associate respiratory rate. Now, respiratory rate is not tricky in COVID. We have to intubate. This is my feeling. And
no, I fully agree with you. This is a very tricky point. Well, I'd like to thank you all. I'd like to thank you, Paulo, for your great talk. You, Chiara, thank you so much for being here. Andrea, nice to meet you. Great
Many
talk
thanks.
about coagulation. This is a very important subject, and we have to discuss a lot. We are in the tip of the iceberg concerning the understanding of the pathophysiology of COVID. Even though we know a lot, we remain in the tip of the iceberg. And I'd like to thank you, Professor Celso Caruso Neves. Great data, very innovative. Thank you all for being here. We are a little bit late, as always, but Ana Paula is telling on behalf of FESB, I would like to thank you all for sharing with us this important work. Thank you so much for being here, and I hope to see you soon, not virtually, but presentially. Thank you so much. Bye-bye.
Thank you. Excellent.
Thank you. Bye-bye.
Bye.
Thank you. Nice to meet you guys. Bye.
Nice to meet you.
Bye-bye.
Nice to meet you too.